Good afternoon, everyone. Good afternoon, everyone. I present a study on comparative evaluation of enzyme-linked immunoassay and chemiluminescence immunoassay as a complementary diagnostic tool in SARS-CoV-2 infection. Introduction. The current global fight against coronavirus disease is to flatten the transmission curve by test, trace, isolate approach as promoted by WHO. RT-PCR is considered as the gold standard method for screening and diagnosis of SARS-CoV-2 infection, but sensitivity of the test is variable depending on sample type, suitable sampling technique, time of infection, and viral load. Whereas antibody immunoassays are easy to perform and play a very important role in understanding epidemiology in general population and as a serological evidence of previous exposure or vaccine response at an individual level. Employing both the gene detections and the serological method could be a prominent strategy at the situation to improve the diagnostic accuracy of COVID-19. The SARS-CoV-2 antigen to which most antibodies directed are viral spike and nucleocapsid proteins. The RBD region of S1 is of specific importance as many antibodies raised against RBD have neutralizing potential. Multiple vaccines in development target or include S1 RBD. The relevance of serological test is highly related to the clinical performance, hence antibody assay with good sensitivity and specificity are needed. The purpose of the current study is to assess the performance of ELISA and CLIA detecting IgG anti-SARS-CoV-2 antibodies. The aim of the study is to compare and evaluate ELISA and CLIA as a complementary diagnostic tool in SARS-CoV-2 infection. Objective of the study is to diagnose COVID-19 using ELISA, CLIA, and RT-PCR to compare and evaluate the ELISA and CLIA in detection of SARS-CoV-2 antibodies. Materials and methods. It was a prospective study. The study was conducted over a period of 6 months. My sample size is 90. In the study group, 30 RT-PCR positive serum samples and 30 RT-PCR negative serum samples were included. Serum samples were collected from patients with duration between RT-PCR test and blood collection more than or equal to 21 days. Control group consists of 10 serum samples, which were collected before the emergence of SARS-CoV-2 and it was stored at minus 80 degrees Celsius. For post-vaccination, 20 serum samples were collected from individuals who received 2 doses of vaccine and had no prior SARS-CoV-2 infection. Serological assays for ELISA, COVID Kavach IgG ELISA kit was used, and the antigen was a whole cell antigen, target antigen whole cell antigen. For CLIA, Siemens Advia Censure SARS-CoV-2 IG assay was used, which was a qualitative and quantitative test. Here, the target antigen was S1 RBD antigen. Results: a total of 90 serum samples were processed for SARS-CoV-2 IgG antibodies. My participants' mean age was 33.13. Among the 38.3% were male, 61.7% were female. Mean of sampling window distribution was 34.08 with standard deviation 8.890. This table shows the total number of symptomatics and asymptomatics participated in study and how many were RT-PCR positive and RT-PCR negative. This table tells the sensitivity and specificity of ELISA and CLIA. Sensitivity and specificity of CLIA was higher than that of ELISA. This table individually shows the sensitivity and specificity of ELISA and CLIA in symptomatic and asymptomatic patients. Sensitivity and specificity was significantly different between ELISA and CLIA in asymptomatic patient serum sample. Since the sensitivity and specificity was significantly different between ELISA and CLIA with p-value less than 0.05, all 10 pre-pandemic samples were negative for ELISA and CLIA. This table it shows a post-vaccination IgG antibody. Both of my participants they took Covishield Covishield vaccine with positivity rate of the test was 100%. Discussion. Even in other studies, if we see the CLIA sensitivity and specificity was higher than that of ELISA. In a study done by Shushmita et al., CLIA sensitivity was 82.6%, ELISA sensitivity was 75.6%. In our study, CLIA sensitivity was 93.3%, ELISA was 80%. A possible explanation of the result could be because evaluated assays detect different antigen. Antibody response against each antigen may develop at different times. Antibodies against S protein are more specific and associated neutralizing capacity. The false positive is more in ELISA compared to CLIA might be due to higher analytical sensitivity or lower cutoff by ELISA or non-specific binding of other antibodies or cross-reactivity for antibodies against endemic coronaviruses. In my study, the patients took Covishield vaccine. The gene encoded for SARS-CoV-2 spike glycoprotein, whereas in the CLIA, the target antigen was also S1 RBD antigen. So that might be the reason for 100% positivity rate. Conclusion: the ability of CLIA to detect antibodies both in symptomatic and asymptomatic patient sample makes it more reliable tool to clarify the true prevalence of COVID-19 within the community. Other advantages of CLIA are faster turnaround time, longer calibration stability, ability to perform other immunoassay testing concurrently, and